Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from F. Hoffman LaRoche Limited.
Hello, I'm Solange Peters, Professor and Chair of Medical Oncology and the Oncology Department at the Lausanne University Hospital in Switzerland. I'd like to welcome you all to this discussion titled Conference Insights, Breaking Developments in ALK-Positive non-small cell lung cancer and extensive stage small cell lung cancer. But I will not be alone during this discussion, of course, but I have the real pleasure and honor to be with high-level experts and friends, Rafał Dziadziusko, who is Deputy Head of the Department of Oncology and Radiotherapy at the Medical University of Gdańsk in Poland, and Shirish Gadgil, who is Associate Professor of Medical Oncology at the Henry Ford Cancer Institute at the University of Michigan in Detroit, USA. Welcome to both of you. Today, we are going to deep dive and review the major practice-changing data in lung cancer from the recent World Lung Conference and the ESMO 2025 congresses, and their potential implications that we might bring to our patients for our evolving patient care. We'll focus on two particular chapters and areas with lung cancer: ALK-positive non-small cell lung cancer and extensive stage small cell lung cancer today. So let's immediately start with ALK-positive, ALK-rearranged non-small cell lung cancer, trying to move from what we know to the early stage, ALK-positive non-small cell lung cancer, the resectable early stage disease, trying to understand if we can incorporate in early stage the other knowledge that we've been acquiring in the recent 10 years in this disease. So first of all, the main, I would say, hurdle in applying what we have learned in advanced disease in early disease is the testing methodology. We were not really used to look for oncogene addiction and biomarker in early disease. At maximum, we are looking at histological subtypes and time after time, maybe PD-L1, but now we need to implement some biomarker testings for an adjuvant or even a neoadjuvant perioperative strategy, knowing that probably you'd like to know from the very beginning of your treatment decision if there will be or not a targeted therapy. Meaning that I would like to stress that even if you decide to go for adjuvant EGFR TKI or ALK TKI, and if you decide to give neoadjuvant treatment, you will not give the same neoadjuvant treatment if you have or not these mutations. So our feeling today is we need potentially to implement PD-L1, of course, but NGS, a small panel in early disease at initial biopsy. And here I will visit very rapidly with you the consensus of the ES-SCLC about perioperative treatment in resectable non-small cell lung cancer. For ALK, based on the ALINA trial, patients with stage 1B, more than 4 centimeters to stage 3A, can receive adjuvant chemo. This was not included in the trial, but can be considered. And to my opinion, I like to consider it for these diseases with a high risk of relapse. But at the end, they need to receive 2 years of alectinib based on the ALINA trial. Thinking about ALK, of course, we've been developing first, second generation, and now even third generation ALK inhibitors, the third generation being lorlatinib, over a period of time of 10 to 15 years. What we like always to show that, and here we speak about advanced disease, the swimmer plot, the lines are about frontline, the PFS1, right, on the current ALK TKI. So all of this compound with various toxicity profile perform very well in the metastatic setting. So here I might ask Rafał to tell us about the early stage with ALK. How do you use this compound? And we have been seeing from these data, right, adjuvant trial using alectinib, the ALINA, using enzartinib, the ELEVATE trial, So how, as compared to the ADAURA trial, right? How do these compounds perform in the ALK-positive disease in the context of the adjuvant setting? Rafal.
Well, first of all, it was a pleasure to present the data for Alina with median of 4 years of follow-up and to confirm the major disease-free survival benefit in patients treated with alectinib versus chemotherapy. Alectinib was given for 2 years versus chemotherapy was given up to 4 cycles per our standard of care, which is platinum-based. With the initial analysis with the hazard ratio of around 0.2 at 4 years of median follow-up, we see here a difference between disease-free survival curve, which holds, which is an important fact, and that with the hazard ratio of roughly 0.35, which means that still the curves are separated and confirms the durable benefit from ALK inhibitor. We also were afraid a little bit that the separation between the curves may diminish over time. At this point of time, we cannot really see that, and the separation holds. Moreover, there is a big difference in favor of alectinib versus chemotherapy in the CNS control. Roughly 90% of patients given alectinib were free of brain metastasis after the median of 4 years versus 75% of patients given chemotherapy, which again reconfirms that ALK inhibitors, here alectinib, has the propensity to stop the disease from going to the brain, which we know is devastating for our patients. Now, during the ESMO session in Berlin, we also could hear the result of phase 3 trial Elevate by Dr. Yuan colleagues with ensartinib. Here, the ALK inhibitor is also the second generation drug, which in the primary readout from this study showed us similar benefit in terms of disease-free survival, acceptable toxicity, and a hazard ratio of 0.2, reconfirming that the paradigm holds true for other ALK inhibitors. In my practice, ensartinib is not available, but possibly for the future, it's important also to see this benefit, which hopefully will hold with the longer observation time.
Thanks so much. It's right, we don't have access into ensartinib in Europe. So, Rafal, we speak about, and we've been seeing the same story with EGFR. We speak about adjuvant alectinib. So, are we going to move into trying to position ALK inhibitors and alectinib in the neoadjuvant setting, and do we have data about it?
We have the readout from the Nautica study, which was presented at World Lung Conference this year. This was a phase 2 trial showing that alectinib, when given ahead of the surgery in these patients, can be given safely for 8 weeks. In this patient subset, the complete pathological response rate was 25%. Most of these patients should be treated with alectinib after surgery, at least for 2 years based on Alina study. And to be honest, I think that we have pros and cons here. First of all, this is only a phase 2 study, proof of concept study that needs to be studied further. Secondly, I'm a believer that the surgery needs to be a primary treatment for all those resectable patients with ALK-positive disease, because pathological complete response in this setting may not have the same meaning as pathological complete response in patients treated with neoadjuvant chemoimmunotherapy outside of the alectinib field. So this is an intriguing proof of concept. I think for the moment, I will stay treating most of my patients with alectinib post-surgery. and we should see in the future how this field evolves.
I would agree with you. I feel always hesitant to consider that, on the contrary of chemo IO, and we know the chemo in the neoadjuvant since decades, I would feel less confident, for example, to adapt my surgery to the regression of a tumor if it's a TKI. Remember, with chemo, if you have the bilobectomy planned and you can reduce it to lobectomy, you're fine. Are you fine with a TKI? I'm not sure. And you are a radiation oncologist, I'm not so sure that you are fine reducing our volumes, because nothing's tell you about sterilizing the region where the response is observed, right? So I always felt like we miss the biological data supporting the neoadjuvant strategy in this oncogene addiction. Would you agree with that?
I fully agree, Solange, and I'm looking ahead how this field will evolve, staying with the principles that we already have.
Yeah. So let's move to advanced disease, because still we had also some news in the advanced disease, and we had two important trials visiting two paradigms. The first one is the first long-term observation of overall survival with second generation ALK inhibitors, the ALEX study. And the bright star, which mimics a bit what again we've seen with EGFR, which is a combination of local treatment, radiation surgery with brigatinib. So taken together, how do you consider this data in your paradigm of treatment for ALK advanced non-small cell lung cancer, Shirish?
So Solange, I need to start off by saying that I need to emphasize for the viewers of this session that there was a simultaneous publication in Annals of Oncology where you're the first author for the phase 3 ALEX trial. It's really amazing to see. This is one of the longest followed trial in advanced non-small cell lung cancer. And what this showed was that the median survival with first-line alectinib in advanced ALK-positive lung cancer is 81 months, almost 7 years, compared to approximately about 57, 58 months with crizotinib. And I think this highlights the utility, the value of alectinib as first-line agent. I will say that after the presentation of the CROWN results, the 5-year update, and last year's ASCO, my sort of practice had moved towards more using lorlatinib as first-line agent. But I think the ALEX results showed that we need to be a little more precise in our decision-making process. There are clearly patients who derive significant benefit. One subset that I found interesting in the ALEX trial is that when you compared patients who had baseline CNS metastases and patients who did not have CNS metastases, the median survival with alectinib in the patients who had CNS metastases was about 5 years. It was about 63 months. Now, the benefit compared to crizotinib was much better. However, the median survival in patients who did not have CNS metastases was 94 months, almost a 2.5-year difference. This indicates the prognostic importance of brain metastases. And maybe can we, as we get more and more long-term data from ALTA-1L with brigatinib, from CROWN results with lorlatinib, could we come up with an algorithm that will help us identify the most appropriate ALK TKI for a specific ALK-positive lung cancer patient, rather than just saying ALK-positive disease, use lorlatinib or use alectinib? I think all these agents, and I think the phase 3 ALEX data emphasizes this, has a role. Coming to the Bright Star analysis, this was a relatively small study, a single center study of 34 patients that incorporated local consolidation therapy after giving brigatinib for advanced stage ALK-positive lung cancer patients for about 3 months. And what they showed were interesting results, a 3-year PFS with brigatinib of 61%. Just to provide a perspective, the 3-year PFS in the ALTA-1L trial with brigatinib was about 46, 47 months. So there does seem to be an improvement. They also showed when they analyzed the data further, and again, I want to emphasize only 34 patients, but there seemed to be greater benefit in patients who had limited number of oligometastases as compared to patients who had extensive metastases. And so I think what this data shows, and sort of goes along with the North Star data that was presented at ESMO this year. That was an EGFR mutation positive patient. Sort of similar results. That was a much larger study that showed a benefit with incorporation of local consolidative therapy. I don't know that I necessarily change my practice based on the Bright Star study, but I do think that I'm likely to consider incorporation of local consolidative treatment, mostly radiation, very occasionally surgery, in the right patient, particularly a patient who has limited amount of metastases where it is possible to do local consolidative therapy.
Thanks so much, Shiresh, for this, I would say, summary of what we know about advanced disease. And we've been seeing together how well tolerated second generation ITKI have created a new standard of care in the adjuvant setting. And we've been discussing advanced non-small cell lung cancer with all the paradigm of even another generation with lorlatinib and the further compounds to come. But what we know is we're improving, right? We're also facing some toxicities long term with lorlatinib, the weight gain, something which are kind of difficult of controlling and managing. But I think we're learning at every big conference about data, benefit, and potential also management and supportive care for these patients. So thanks so much. I think we've covered the ALK topic. I'd like to now maybe jump into the second topic, which is small cell lung cancer. Small cell lung cancer it's an interesting disease because for decades it has been not even really evoked or spoken about in congresses. The main advance we've been making in the past in extensive stage is to add anti-PD-L1, durvalumab or atezolizumab, to chemotherapy with maintenance anti-PD-L1 for a benefit of roughly 3 months of overall survival. So it was an advance for sure, with some 10 to 15% long-term benefit for the patients, but we will all agree that we are still all expecting better than that. It's interesting, between, I would say, 2019 and 2025 in non-small cell lung cancer, we've been seeing so many new drugs, like maybe 30 approvals, including numerous new modes of action, right? But not in small cell. In small cell was the atezolizumab, durvalumab. We've been recently seeing in the exact same context tislelizumab, an anti-PD-1, and serpulimab, sorry, an anti-PD-L1, all showing the same small benefit in survival. So we need to move from there, right? And that's why we try to convey today is we have started to do so in front line, but also in late lines. So first important thing is the maintenance. At the time being, maintenance was just continuing atezolizumab, durvalumab, tislelizumab, serpulimab. But now we have another maintenance, the IMforte trial. So IMforte is maintenance with lurbinectinides. Do you want to tell us more, Shirish, also about the safety and maybe how disease progresses after this kind of maintenance? A bit more about the whole story of IMforte, please.
Yeah, Solange. So this was, I think, in my opinion, quite an important trial. As you very well know, maintenance therapy has been evaluated in small cell lung cancer for a very long period of time. And the primary reason is, despite the high response rates with platinum etoposide, a good proportion of patients progress quite rapidly after you stop the initial 4, or sometimes in the past we used to give 6 cycles. And so there was an interest in looking at maintenance therapy, but none of those trials showed any benefit. And so it is in that context that the benefits seen in the IMforte trial are, I feel, impressive. So in this study, patients who had completed 4 cycles of chemotherapy and a checkpoint inhibitor, specifically atezolizumab, and had experienced either a tumor response or stable disease, were then randomized to continuing with atezolizumab as maintenance therapy, or the combination of lurbinectedin and atezolizumab. Important to point out that lurbinectedin was given at 3.2 milligram per meter square, administered every 3 weeks, and atezolizumab at 1200 milligrams every 3 weeks. And I only mentioned that because normally in the maintenance setting, we tend to give 1600 milligrams of atezolizumab every 4 weeks. So in this study, to match the lurbinectedin schedule, atezolizumab was dosed at 1200 milligrams every 3 weeks. And the study showed both a PFS and survival advantage. The median PFS with the combination was 5.4 months. compared to atezolizumab, 2.1 months, which is what one would expect based on the Empower 133 and the Caspian results. And the survival was about 13.2 months with the combination as compared to 10.6, a hazard ratio of 0.73. So both a PFS and survival advantage. But there were a couple of interesting data sets regarding the sites of progression. So what was seen is that there was greater occurrence of brain metastases at the time of progression in the combination arm as compared to the atezolizumab. And this may speak to, I think, possibly two things. As the patients live longer, they are more likely to progress in the brain. And there is also a possibility that lurbinectedin may not be as effective against brain metastases as it is effective against other site of disease. Also, interestingly, when one looked at the baseline tumor burden, there appeared to be greater benefit in patients who had a higher tumor burden as compared to patients who had lower tumor burden. Again, these are subset analysis. How to incorporate these data sets into treatment, into sort of day-to-day management of small cell lung cancer patient is unclear. I think that the reason why this is relevant is that it is not always possible to do maintenance therapy in all small cell lung cancer patients after completion of initial chemotherapy and checkpoint inhibitor treatment. And the reason is that these patients can be quite fatigued. Their bone marrow may be somewhat compromised with the initial chemotherapy. And so one needs to be judicious in deciding in which patients to use maintenance treatment. So even though the data is positive, I think this is not something that can be easily done in all patients. For example, patients who are elderly, patients who have comorbid illnesses, it may be challenging. And I'm not suggesting that these patients should be excluded from maintenance treatment, but one needs to be cautious. One thing I do want to mention is that in the study, all patients on the combination arm received growth factor support. And despite receiving growth factor support, cytopenias, including neutropenia and neutropenic fever, were seen. So, absolutely an important study. It is very nice to see for the first time that we see a survival advantage with maintenance treatment. But the study results also show, based on both the sites of progression as well as the safety data, that one needs to be judicious in the use of lurbinectedin as maintenance treatment.
Thanks so much for all these insights. So I think this IMforte trial has been, of course, we need longer follow-up, right? But I think it has been nicely described in all the parameters that you'd like to know about, right? The pattern of progression, maybe some patient selection, of course, the difficulties that you might encounter using the strategy. So I think the unanswered question for me, one would be the long-term benefit. Do you really ride the plateau somewhere? And the other thing is, of course, and there's not an answer we're gonna have, right? But what to do with these patients who have brain mets? It remains chemo, right? We know chemo might have some efficacy. So I'm not so sure I would exclude a patient for with asymptomatic brain met from this opportunity. However, they were not included in the trial. So I think we might go a little beyond the inclusion criteria because we don't really have any decent alternative at the time being. Would you agree with me?
I completely agree. And thank you, Solange, for bringing up an important part of the eligibility criteria, which I forgot to mention, that patients who had a history of brain metastases were excluded from this study. And I think that is a limitation of this trial, very frankly, particularly in this patient population, which has a high risk of brain metastases. But I agree with you that though the study excluded it, in my practice at the present time, I'm not necessarily excluding those patients. But having said that, I do try and treat the brain metastases as much as possible, particularly with SRS, before starting them on maintenance treatment. I think you ask a very important question as to whether there will be, with long term data, could we see flattening of the curve? I remain somewhat skeptical that we're going to see a flattening of the curve. But I think why this is quite relevant is, with all the new drugs that are being evaluated in small cell lung cancer, if we can prolong progression-free survival in these patients, it may provide an opportunity for these patients to be treated with many of the newer drugs. And so maintenance treatment becomes another avenue to test newer agents in small cell lung cancer.
Thanks so much for bridging for me to the next chapter. And now in second line, right, we have lots of antibody drug conjugates and also new strategies. So the time is sometimes just meaning opportunities, right, for patient. And surprisingly, the field is moving so fast in small cell lung cancer now that every month might be new opportunities, right? So probably the best established today is antibody drug conjugates, a bunch of these, but that's not the topic of today because I'd like to focus on other immune mechanism and particularly what we call T-cell engagers being antibodies or bites and the growth of data about tarlatamab. So we've been seeing tarlatamab in many settings, in the second line setting compared to classical chemotherapy, but also, and it was about Wordlong and ESMO, combined with an anti-PD-L1 as maintenance again, just to bridge with the maintenance from Sirish after the usual chemoimmunotherapy frontline. So based on this data, Rafal, how do you interpret the risk profile of adding DLL3 T-cell engager bites, right, tarlatamab, in the maintenance setting? What do you think about it?
Well, we now have only preliminary data, both on tarlatamab, but also on obrixtamig, which you nicely presented, Solange, at ESMO 2025 in Berlin. We know that tarlatamab is a very interesting drug in terms of mechanism of action. The early phase data are really very promising. The second line data look also very interesting. And now the drug, this and the other ones, move very quickly to the first line setting. We heard about the phase 1 trial combining chemotherapy with tarlatamab and atezolizumab or durvalumab, showing the acceptable safety profile and also very encouraging but very preliminary overall survival of roughly 80% at 1 year, something we've never seen in small cell lung cancer extensive disease. So in terms of safety, this looks very different in the second line setting, but also in the first line setting, than say that the toxicity profile from chemotherapy. We typically see like febrile neutropenias, like nausea, vomiting, like anemia, thrombocytopenias, and others, not mentioning hair loss. Here, when these drugs are given in monotherapy or combination, we see mainly ICANS and we see mainly cytokine release syndrome. Also, something that's important to mention about DLL3 engagers is loss of appetite. This is something that may seem not so much relevant for the patients, but it really is. The loss of taste means that patients do not eat well and they really lose their weight. So I would say prepare for the new treatment related toxicities. The ICANS can be figured out very nicely based on the questionnaires. The cytokine release syndrome needs intensive monitoring, especially during the first 2 cycles of tarlatamabs or other DLL3 engagers, and can be usually quite light, meaning grade 1 or grade 2, when it doesn't really improve on fluids administration. You need quickly to monitor the patient, administer steroids, and eventually IL-6 antagonists to make sure that your patients are doing fine. So we are learning all that. We are hoping that in the future we'll get to outpatient care. For the moment, it's not very much so. Hopefully, this will change in the future.
Yeah, it's very, very interesting to see these drugs being developed, and also the algorithm and how to manage the patients is being refined. We've been seeing in late lines, you've been describing very nicely the toxicity profile, and of course the benefit against chemotherapy in relapsed and refractory tumors. It's quite interesting to see that some patients were treated out of the hospital, out with a kind of a surveillance for 6 hours or so, which by the way is a strange timing, because if anything happens, it's beyond, right? It's 13 hours. So why would you keep them for 6 hours? But when they were outpatients treated, right, it looks like even CRS declared is lower, meaning probably that when you don't have a nurse behind you measuring the fever every 4 hours as it should be, you probably missed some of these events. But the most important parameter was that there was no catastrophe. Nobody came and died from a late kind of detection. But of course, this is still clinical trials. So we need to learn what is the real life telling you about management, inpatient, outpatient. So we will learn way more. Question to you, Rafat. Something you haven't not covered is second line, maintenance, or front line. So what will be your idea about the mechanistic and the various reason why we have been seeing data in maintenance, we've been seeing data in front line, cycle 2, day 1, we've been seeing data in late line. So what do you think would be the most, I would say, relevant strategy in the future?
For me, I'm quite positive that we are moving strongly to the first line setting. Of course, it remains to be seen. Of course, small cell lung cancer means that patients may present in quite miserable condition at presentation, depending on the situation. But I'm quite positive that it will gain momentum in the first line treatment based on early tarlatamab. So we'll see in the future. It for the moment it's my bet, but given the mechanism of action, I have no doubt that this will be the future.
Yes, we did present this obrixtamig, which, on the contrary of tarlatamab, is not a BiTE, it's not a peptide between the two binding sites, but it also binds DLL3 and CD3, but it's a real antibody. We thought it would make a difference. It doesn't look like to make so much of a difference in terms of efficacy and toxicity. But the obrixtamig was also tested, but not from cycle 2D1, but from cycle 1G1 with chemo and atezolizumab or durvalumab. And the main question was, is it feasible? It was a phase 1. So both trials converge to say that it is feasible. Surprisingly, there's no unexpected synergy in terms of toxicity. We don't know about efficacy, but we need longer term outcome. So maybe Suresh, a provocative question to end. Maintenance data with tarlatamab are a combination of this T-cell engagement plus the anti-T cell exhaustion, meaning an anti-PD-L1, usually in that setting. In the front line, same thing. You have chemo, checkpoint plus tarlatamab. But in the second line, it was monotherapy. So maybe we should follow the principle of fighting against T-cell exhaustion and always give a checkpoint beyond progression in second line. Tarlatamab maybe needs to be coupled with a checkpoint. What do you think?
I feel not so fast. I think that the data is based on single agent tarlatamab compared to chemotherapy. And mind you, all these are patients who have progressed on chemotherapy and a checkpoint inhibitor, and it is unclear whether continuation of the checkpoint inhibitor and addition of tarlatamab will necessarily provide any greater benefit. I also feel that we need a little more data and understanding as to if a patient has experienced immune related AEs. Can those patients tolerate a drug like tarlatamab? That is, will there be an overlap between the toxicities? So at this point, I think I would stick with the data from Delphi 304 that showed that there was a survival advantage with monotherapy tarlatamab.
So thanks so much. Thinking about future ease to give treatment, let's keep in mind that many of these checkpoints start to be subcutaneous. Atezolizumab is subcutaneous. Pembrolizumab is coming subcutaneously. Let's remember that also it's a good thing for the patent of the drug because they are prolonged. Let's be very fair. But we also need see some drugs coming subcutaneously for toxicity reason, amivantamab, for example, in GFR, which reduces the infusion reactions. And we heard a little bit about tarlatamab subcutaneous, which might also reduce a bit CRS because of probably pharmacokinetics. So the future might also be about understanding more the pharmacology of what we do, and it might change the ease we have to deliver, but also the toxicity profile. So it's quite interesting to continue to observe. This being said, we reached the end of our wonderful discussion. I'd like to thank you both, Rafael and Shirish, for this great exchange and discussion. And thank you all for participating in this activity. Please continue on to answer the questions that follow, and please complete the evaluation. Thanks so much.